Okay, so this is part two of Stop the Guessing Game, implementing a criterion and evidence-based functional performance testing algorithm for the foot and ankle. We'll be focusing on postural control and balance assessments. Let's get into postural control assessments for the foot and ankle and lower extremity. Related question, does postural sway correlate with ankle injuries? Postural sway is a risk factor, and we can see that the consensus here is a little bit more unanimous with 86% of the papers. That is 5 out of 7 of them demonstrating that there is postural sway does have a correlation with ankle injuries, with an inverse relationship. That is, the better the postural sway, the lower the postural sway, or the better that is, the lower incidence of ankle injuries. And we can see here with the bullet points that increased variance of postural sway, similar to what we had seen in the previous slide, particularly again with basketball athletes, that this has an increased risk of ankle injury rates within the athletic population. Assessments such as this star excursion balance test and measures of center of gravity of sway have been effective at identifying individuals at risk for ankle sprains. And these tools have been shown that athletes with worse postural stability are more likely to sustain ankle injuries. And then on a population level study, we can see that the high school basketball athletes, again, they study those athletes in particular because of the high prevalence of the rolled ankle, that there's an increased postural sway scores are more susceptible to ankle sprains. That is, with an increase in postural sway, that they're less stable. And the balance assessments could be used as screening tools to recommend balance training and potentially decrease injury risk, both primary and secondary, as previously described. Granted, as I alluded to, that the confounding variable here is that history of ankle sprains can in itself impair postural stability, and we know that prior injury is obviously one of the highest, if not the highest, risk factor for recurrent injuries. Usually the consistent location, but also on the contralateral limb at times. That makes postural sway at times, or impaired postural stability, a confounding factor in assessing the risk or future risks of subsequent ankle sprains, just because it may otherwise already be compromised when we're looking at individuals who have already sustained the ankle sprain or injury. This highlights the importance of considering previous injuries when evaluating the postural sway as a risk factor. Okay, so let's talk about postural control. So from the dynamic systems theory, in that perspective, there's really 3 components that make up and determine one's postural control. You have the organism or the individual, the postural task, as well as the environment. And then if we break it up a little bit further, right, and you can see that there's different components within each of those 3 primary ones. So for the individual, you have the motor, the sensory, as well as the cognitive component. For the postural task, you have the actual proactive nature or the reactive nature, and whether it's steady state or dynamic. In the environmental domain, you have the support surfaces, the sensory context, as well as the cognitive load or the sensory stimulation and the arousal state of the individual or organism based upon the busyness or the openness of the environment. So let's take a closer look and focus most on the individual at this time point. So within the individual, as I alluded to in the previous slide, is that we have the motor, the sensory, as well as the cognitive aspects that play into one's postural sway performance. But the reality of the situation is postural sway is a conglomerate of a complex internal system, and not only from the neuromuscular and the motor, but again from the central nervous system as well as the periphery. if we try and quantify each of the components that play into that, we can see that on the whole, there's really six major categories, that being the musculoskeletal system, muscle synergies, sensory system, sensory organization, cognitive strategies, and cognitive resources or bandwidth. And so I present this as a recognition that there can be a multitude of rate limiters that can negatively influence one's postural control, even though we're going to synthesize it down into quantifiable numbers and or errors or certainly values. And so if you see impairments here, it's not, it would be a mistake to simply just assume that it is truly due to, for instance, just the musculoskeletal system or altered muscle synergy or sensory alterations from the ankle. It would be important to also consider potentially the other domains within the organism and within the central nervous system that could potentially influence the postural control evaluation and outcomes. And to that end, some of these things that can play into that, right? Age, sensory function, visual, vestibular system, one's proprioception. We know that individuals post-injury, particularly in the foot and the ankle, have shown to have altered joint positional sense, as well as because of the interference with the mechanoreceptors, this also can influence and negatively influence the information that's coming up from the limb, right? And you can look to Dr. Dustin Grooms from The Ohio State University and his group, as well as his colleagues who have done extensive work looking at the altered information that comes up from the limb and the changes to the brain plasticity and sensory reweighting. Certainly certain health conditions can negatively influence this: cognitive function, muscle strength, joint mobility, body composition. And so it's important to recognize that this is, again, an aggregate, a conglomerate construct that we are measuring. And though we want it to be symmetrical and fall within norms, it does necessitate potentially going and investigating on a deeper level in order to identify what the deficits otherwise are. All right, so there's going to be three primary domains or subsections of postural control that we will assess. So we can lump these into steady state postural control, which is defined as the ability to control the center of mass related to the base of support in a fairly predictable and non-changing condition. Examples of some of the outcomes that we can get from this is the duration of time that someone's able to maintain a particular position or posture without losing the center of mass outside of their base of support, requiring them to utilize a stepping reaction, postural sway, the number of faults over a given amount of time. A fault can otherwise be defined comparable to that of the balance error scoring system, where you have a foot touchdown, someone's trunk deviates greater than X amount of degrees, knee varus or valgus, so on and so forth. Performing platform deflections if you're on a stabilometer, and or the change in center of pressure metrics, which we will talk through, and there's others as well. The second is going to be your anticipatory postural control, and this is the ability to activate muscles for balance control in advance of voluntary movements. An example of this would be your standard star excursion balance, which would be, or your Y balance test, where the individual is given specific instructions to reach in a particular direction, and they know what's coming. There's no tempo or reactive nature to this. Examples of this would be reach distance, postural sway, once again, platform deflections, if you're on an unstable surface or stabilometer, and then again, change of pressure. Reactive postural control is where there's some perturbation to the individual that is unanticipatory. The ability to recover a stable position following an unexpected perturbation. Again, similar to the metrics or outcomes from that of the previous two domains. The difference here is that you also can incorporate time to stabilization. And so we'll look at these three different subsections of postural control, and the different abilities within each, and break it down into more of a level format, and also consider what types of tools and assessments would be appropriate for each. Okay, so we have those three separate domains of postural control. What are our tools to be able to accurately assess the different domains? So here I've listed out the different categories from the gold standard all the way down to questionable. The gold standards being the Neurocom SOT Balance Master, lab-based motion capture systems to look at postural sway and joint angles and joint kinematics. And then we also have the triaxial force plates that look at center of pressure, measurements, time to stabilization, time to boundary, so on and so forth. The majority of us probably don't have access to this on a regular clinical basis. The other tools at our disposal that we can endorse would be the stabilometer. Uniaxial force plates are becoming much more common. Utilization of mobile-based devices, be it our phone or iPads, where we can use app-based or the gyroscopes within these mobile devices to be able to assess postural control and velocities of movement. The battery of different field tests if we don't have any technology available to us, and the questionable efficacy of the standalone field test. Right, if we're going to be utilizing field tests in general with low technology, because these are these subtle changes in center of pressure as well as postural sway, it's better to be able to quantify these as well as like even just the velocity, not only just the amplitude of the movements. Well, then we need to be utilizing a variety of different assessments in order to be able to get a more robust assessment of someone's postural control, particularly when we're looking at different domains. So here I provide the definitions of what I mean by gold standard: good, acceptable, sufficient, and questionable. So good being good to excellent reliability and validity. All 3D motion and triaxial ground reaction force vectors can be accounted for. Extensive published research with the utilization of those tools. Good reliability and validity would be considered this good category. Dual axial center of pressure changes. They're clinically friendly with sufficient training of the clinician. The acceptable category would be good to acceptable reliability and validity. We get 2D postural sway capture, easy for clinicians to implement and access as well as to administer within the clinical day. The sufficient category is going to be acceptable reliability or validity, requiring multiple assessments to ensure comprehensive postural control, competency, and then ease of clinical application. And then finally, the questionable: acceptable reliability, questionable validity at times, insufficient to fully capture postural control competencies across different domains, and particularly insufficient to capture it even in one, and subject to ceiling and flooring effects. And so we'll kind of keep these categories in mind as we move forward with the different assessments. Okay, so when we consider the different domains, the steady state, the anticipatory, and the reactive postural control, what are our assessing tools that we can utilize that would meet certain standards? The biodynamics balance system for postural stability testing, limits of stability, as well as single leg athletic balance has, so if you have availability to that balance assessment, you can assess all domains. For the force plate, single leg stance, force plate for the steady state postural control, single leg squat or the star excursion balance test with or without force plates would be recommended for your anticipatory. And then we also have our single leg land and hold and time to stabilization for the reactive component if we're utilizing force plates. The acceptable categories would be your balance error scoring system with postural sway metrics added on rather than just the errors themselves. Time lateral step down, again with postural sway metrics, would be recommended. And then the single leg land and hold with postural sway metrics also included. And then our sufficient category would be our modified CTSIB, or our single leg stance, our wide balance test, our time lateral step down, and then our reactive wide balance or four-square hop test, which we will talk about. And so you would, if you're going to utilize things that is tests within the sufficient category, it'd be ideal to use a cluster of assessments from multiple domains. Okay, so what does this actually look like in clinical practice? So we have our different types of postural control that we've talked about. I've used this symbolization for each respectively. And so I use a 5-level system going from progressively easier to progressively more difficult assessments. And so the level 1 is going to be our stable surface static balance. Level 2 is going to be unstable surface static balance. Level 3 is going to be our stable surface dynamic feed forward balance. Level 4 is going to be stable surface, once again, dynamic feedback balance now. So there's more of a reactive component, and you can see that by the symbolization. And then phase 5 would be, or level 5 would be our single leg ballistic dynamic balance. And so I've found this to be a relatively robust model to utilize to ensure that there's a progressive nature to our assessment, as well as a progressive nature to our interventions. And what I'm going to endorse is that whether you use the assessments that I propose today, or you take the principles back to your clinic and select what is appropriate for your clinical setting for each of the domains, I would say that this would give you a robust understanding to ensure that each of the components of steady state, anticipatory, and reactive postural control for your foot and your ankle, and any of your patients that it would maybe deem necessary for would benefit from. Okay, so level 1, stable surface static balance. So you can see the silhouette there indicating the utilization of a force plate. Again, if we have some means of capturing, whether it be center of pressure or the postural sway of the individual's torso, that would be advantageous over just looking at essentially their time or their number of errors within a particular time frame. Level 1A here would be eyes open. Level 2B would be eyes closed for the appropriate amount of duration of time if you're using force plate as shown there. And the metrics that we would look at would be total excursion, which is the path of the center of pressure over time. So the shorter the distance, the more stable the individual. The second would be mean velocity, which would look at how rapidly, essentially the velocity changes of the center of pressure over time. Again, the slower, the better. When we look at the area covered of the center of pressure, you could either consider it for the area of the ellipse, which covers 95% of the trace, or the center of pressure range, which looks at the anterior to posterior, as well as the medial to lateral displacement of the trace of the center of pressure. So each of these metrics have been shown to be effective and valid in measuring the efficacy of someone's postural control during the static balance, and they've also shown that these metrics, particularly the velocity and total excursion, have been demonstrated in systematic reviews of individuals that have history of foot and ankle injuries to be of high clinical utility and be able to distinguish between the pathologic and the healthy. Your cutoffs and your criteria for each. So for your total excursion, you want less than 50% of eyes open versus eyes closed. That means the length of them doing it with their eyes closed should be no more than twice that of their eyes open. For your mean velocity, less than 1.56 centimeters per second. For your eyes open, eyes closed, for your area of the lips should be less than 80%. And then for all of these metrics, utilization of age, gender, and specific norms would be recommended in addition to the individual ones that I've stated above. And we would say that if you're able to capture these center of pressure metrics, that this would be a really good assessment. Note that a single leg quiet standing force plate measure of postural control may be more useful for tracking outcomes in measures in patients with chronic ankle instability than they are for serving as a diagnostic tool, meaning they may not be able to diagnose someone, but they can certainly demonstrate the progress over time. Okay, so as I alluded to, alternative to the force plate would be a stabilometer. In this case, the example is a Biodex balance system. This can be utilized in a multitude of different formats and different assessments that span across the different types of postural control as well as the different levels. In this case, the most straightforward would be a single leg stance on a static platform. You can see that the target is essentially divided up into different zones, each zone representing 5 degrees of deflection. The acceptable single leg balance would be 2.2 degrees of deflection or less for females and 3.0 for males. The duration would be 3 seconds. Again, you could add some perturbation to the platform or unsteadiness. That would be level 12. However, it can go down to, as low as level 8. And then you can also see that the second goal would be that not only for hitting the subject-specific norms for age and gender, but then also for the limb symmetry index of being within 5% would be the end goal. And you can see once again that this is classified under our definition, the conventional definition of a good assessment given its reliability, validity, and so on. So what do the results provide you? It provides you a medial and lateral index, an anterior and posterior index, as well as an overall stability index. You can see the actual scores there, which represent the degrees of deflection. It's kind of like golf. The lower the score, the better. What you also want to consider would be the standard deviations as well. And so that would, the significance of this is similar to the center of pressure in regards to the lower the standard deviation, the lower the length of the trace or trace excursion, which was shown on the force plate. It also, obviously there's a temporal component here as well, right? So you could have very low range of the center of pressure, but if there's high velocity of amplitude within how quickly the center of pressure is changing, that would obviously increase the length of the trace or the trace excursion, as well as your mean velocity would also increase. But in this case, it doesn't give you the center of pressure. It would simply just be the fact that you want to have the lowest standard deviation as possible. Again, you can be comparing this left to right, and then we've given the norms relative to the different genders. Okay, and so for those of you that don't have access to a force plate or Biodex balance system or stabilometer, a field test that is well researched is the balance error scoring system. Traditionally, it's got 6 conditions: double limb stance, very small surface area or base of support, single leg, tandem, and then you do this on firm and foam surfaces. The classic test is described with eyes closed. That being said, I also do it eyes open. Oftentimes I find that there's, at least in the initiation of it, early in rehab, that it can often have a flooring effect where people are unable to balance on a single leg for whatever reason, again, given age, gender, sensory discrepancies, joint restrictions that may still present, so on and so forth. And so then you would look across all 16 different conditions. it'd be 16 different conditions because you're also doing dominant and non-dominant limb, vice versa, not only with the single leg stance, but also in the tandem. Okay, and this would be considered to be a sufficient assessment if utilized in a battery of field-based assessments for the sake that, yes, it captures our stable surface static balance and our unstable surface static balance, but it doesn't really capture the other 3 levels, nor does it have an element of really reactive or feed-forward postural control. You could make the argument slightly with the foam, given the instability of the surface, but again, it's not as though the surface is in itself moving. So there's less of a reactive component, even though that's still somewhat present. Okay, a simple way to enhance the value of the balance error scoring system would be to incorporate modern technology using a mobile device and leveraging the gyroscope. So one example would be the My Jump Lab. So you'd have the individual hold the mobile device or attach it to them with a belt or something of the like. And then My Jump Lab is one example of some of the apps that otherwise exist, and they do have a balance analysis, and you would have the individual hold it, relatively steady. I usually have them push it against their torso such that there's minimal accessory movement. Again, there may be some human error in that, but it would otherwise be minimal. And then it gives you the different axes of postural sway. So it gives you the forward, backward, left, right, and then the lateral inclination based off the movement of the mobile device. And this would be just another layer of granularity in your assessment that you could then use not only to track across time for demonstration of improvement, but the comparison, a more granular comparison of eyes open, eyes closed, as well as left versus right. And then if you make a consistent habit or workflow of this, well, then you can also start to capture more cohort-based data such that you can stratify individuals across what is normative for the patient demographic that you see and treat. All right, and this would be considered acceptable. Again, it gives you another layer of granularity than just the field test alone. Okay, beyond My Jump Lab, another really nice platform out there that has really good research and has done substantial validation in their platform is Sway Medical. Again, no affiliation, no conflicts of interest here, simply just a clinical tool and platform that may be valuable for your demographic and for your clinical practice. So you can invest in, depending on the subscription model that you suggest or utilize or select, right? You can have all of these 4 different components: balance, cognition, function, as well as surveys, or you can just have the balance component itself. Again, it allows you to risk stratify or at least determine where someone sits relative to their age, gender, and demographic norms. It allows for easy tracking purposes within their software, and then it may also give additional elements of dual tasking with the cognitive and the reactive aspects that they offer within the platform. All right, once again, unstable surface static balance. So you could, again, utilize the Biodex balance system and or stabilometer. You can see the example here where the platform level is unstable and the individual is needing to be able to stabilize it on a single leg stance. Usually it's recommended to have about a 30-degree knee bend in the stance limb as a means of really challenging their ankle and having a little bit more validity there. And once again, it would stratify it as good. And then the nice thing about this is that it would provide you also with the actual scores, again, deflection of the platform being the units here, and then you have the standard deviation, and it gives you the normative data for the overall anterior to posterior, medial, lateral indices. And then it gives you a visualization and that's helpful for communication and interpretation of the results to your patient, where you can see the upper bar in blue is going to be your overall index, and then you have the anterior, posterior, and then the medial, lateral, and the bandwidth of what would be the normative range and where they stack up as indicated by the small triangle. Once again, the goal number 1 is to exceed normative scores for each of the different score categories. And then goal number 2 would be 100% limb symmetry indices as compared to the other side. Okay, so just summarizing, what have we looked at thus far? So the level 1, stable surface static balance. You can utilize a single leg balance, again, be it with the force plate, a stabilometer, or a field-based test such as the balance error scoring system, with the option to utilize a mobile device and gyroscope in order to determine and quantify the postural sway in the different directions. You can see the quantified cutoffs for the metrics as shown here, with total excursion, area of center of pressure of the ellipse, center of pressure mean velocity, and the time to boundary. Wasn't previously described, but essentially this is how quickly the center of pressure would get to the boundary of the foot if it was to continue in that trajectory. This is quantified within certain systems if you so choose to or have access to the force plate. And then you have the stabilometer and the different gender differences there. Again, there can be an age component with the deflection, as well as the height of the individual may also influence this. Okay, and this would be, the force plates would be considered good, as would the stabilometer. Level 2 would be your balance error scoring system, or the Biodex, single leg athletic balance, or some other stabilometer, and having that unstable surface. And if you're just using the field-based assessment of the balance error scoring system, this would be the number of faults. Cutoffs would be firm surface, you want less than 3 errors. Total errors, both eyes open and eyes closed, firm surface, and foam surface would be less than 14. And then the My Jump Lab app, you could also utilize and pull from the deflections normative data from, as shown by the stabilometer, as in the degrees of sway. And this would, you could quantify this whether you want to look at in the forward and backwards or side to side direction as well. And again, the balance error scoring system would be sufficient, and if utilized with the My Jump Lab or the Sway Medical, that would be either be closer to acceptable. The Biodex balance system at the single athletic balance would be considered good, and then our cutoff scores for limb symmetry and for the demographic norms would be greater than 90%. All right, moving on to level 3, stable surfaces with dynamic feed forward balance. A primary example of this would be your lower extremity wide balance test, or your standard error balance, or your star excursion balance test. Typical cutoffs for the anterior direction have been less than 4 centimeters, whereas the posterior medial and posterior lateral directions would be less than 6 centimeters. Healthy controls are able to get a composite score of 100%. That is, if you average the reaches in each of the 3 directions and they're divided by the individual's limb length, that should be at least 100%. When we look at the Y balance with a force plate, that would give a center of pressure mean velocities for the anterior, the posterior medial, and the posterior lateral directions. You can see the normative values shown there. Of note, and you can see by the asterisk symbol for the lower extremity Y balance test, is that those cutoffs have been suggested. The developers of the kit have shown that these the normative values as far as reducing risk of re-injury, be it secondary or primary prevention, would be specific, need to be a little bit more specific to the age, gender, and even the sport event of the individual. And so if you're so inclined, you can invest in the Rehab to Perform software that would give you those specific values rather than the more general cutoffs for limb symmetries that I've touted for the anterior and the posterior medial and lateral directions. With the force plate, this would be good. It would be sufficient for just the Y balance or the standard error balance scoring system, and this would be this would need to be, again, part of a battery of assessments if you're just doing field testing. And another example of this would be a time lateral step down. This is touted as an exemplar of your feed for your anticipatory maneuvers or movements in your postural control. Examples here would be doing it at a set tempo of 80 beats per minute, and that would be a tick at the top and a tick at the bottom, so it would be 40 reps per minute. For the dominant limb for males, you're looking anywhere between 114 to 126 seconds, whereas females is 131 to 122 for the dominant and non-dominant limbs respectively. The test stops when the individual either volitionally can't do any more repetitions, or they've met 3 faults. Faults being knee varus or valgus greater than the width of the foot. If they drop their pelvis greater than 10 degrees, or they have a trunk lean, lose balance, have to actually step down, or fall behind tempo without, even after a friendly reminder to keep up with the external tempo. And then you want the individual to have relatively good symmetry of 90% and to be within 90% of norms. And again, that would be a sufficient test if used as a part of battery. And then the cutoff scores for both of these is comparable to what we've seen previously in the other levels, would be that we want the limb symmetry to be greater than 90% and or greater than 90% of the demographic norms. One plug for trying to, again, up the level of granularity and assessment that we perform with these clinical friendly tasks and assessments would be the application of motion capture systems, even friendly apps such as this one is, the example is Yoga, and you can see that in the graph there that it's quantifying the range or the amplitude and excursion of each of the joints of the lower extremity. The one that is being mapped in red is the left ankle shin angle, and then you have the left hip flexion and extension angle, and then the left knee flexion and extension angle in the respective 3 colors. And you can see at the end of the video, it gives you your max and your min, as well as the instantaneous angle. And this would again be deemed sufficient if utilized with a variety of other assessments that capture the different levels of the model that we've proposed, as well as the different types of postural control. Okay, so getting into level 4, the stable surface dynamic feedback balance. So still using the Y balance kit, but now with a slightly different assessment. So we're looking at the reactive Y balance test. So the participants or the individual is instructed to extinguish the lights as quickly as possible. The test begins with the command light. You can see circled there in red. It initiates either blue, red, or green light for 0.2 seconds, which then corresponds to one of the different axes of the Y balance test. The corresponding LED light on the Y balance axis illuminates for 2 seconds, and the patient or client must extinguish the light by passing their foot over the light by up to, within 5 centimeter range. The visual stimuli occur in a random sequence of over 36 to 21 trials, depending on the duration of time. And then the interstimulus times vary between 1.5, 2, or 2.5 seconds to prevent anticipatory movements. And you score the individual on their accuracy score, which is the total number of stimulus minus the stimuli plus the multiple attempts plus the decision of error, the errors that occur, and then the number of stimuli divided by the number of stimuli, which gives you a percentage score. You also have the visual motor reactive time, which is the average time in milliseconds or seconds to extinguish the appropriate light. And the authors do a really nice job of laying out a table that is easily to be recreated, right? So then you have the stimuli running down the first column. I only give examples of 3 there. First column with the green check mark is that they've hit the stimuli, that's accurate. The red would be incorrect stimuli, +1 would be multiple attempts. A decision error would be the yellow, and then a loss of balance would be the in that final 5th column. And then you can easily quantify this, whether you want to use a 1 or 0 score, such that in Excel, for instance, where it will calculate it for you, that's probably the easiest way over time. And then you can see here that the system utilized is the fit light, and so the fit light system will give you the number of hits, that is the total number of stimuli, the misses, the average reaction time in seconds, and then the total time for the assessment. And then you're looking for consistency within 90% from side to side, and then the normative data do exist, which I'll provide to you within the section handout. And this would be, again, a test of sufficiency. It is more of a field-based test that would need to be used in combination with other postural control assessments. Okay, so for level 5, single limb ballistic dynamic balance. So you're looking at 3 different assessments here. You're looking at the single leg land and hold, where the individual drops off a box of 20 to 30 centimeters and sticks it. And you're looking at time to stabilization over 20 seconds upon landing. The second one is going to be the single leg hop and return, where it is done on dual force plates, where you have the individual stand on one leg in silent stance. You then have them hop over to the other force plate and then back. And then the third is your single leg hop and landing, which you can use for your traditional hop test. Usually the way that it's been described thus far is not with multiple hops, with a single hop. So you measure someone's max vertical hop on a single leg, and then you take 50 to 55% of that, and then you have them jump forward and land onto a force plate. Once again, you can look at their ground reaction forces as well as their time to stabilization over 20 seconds upon landing. And previous work that has looked at the concentric contributions for both horizontal and vertical hops have demonstrated that when the calf, the foot and the ankle, and the calf in particular, the ankle work is significantly higher with your horizontal hops than with the vertical, particularly during the concentric phase. And then it would be the opposite upon the eccentric or upon the landing phase, where it accounts for almost just over a third of the total limb work, and you can see that as demonstrated in the percentage score. And if you use one or multiple of these tests, you can capture both the concentric horizontal as well as the eccentric vertical. Okay, so looking at the level 4 and level 5 summary, so the stable surface dynamic feedback balance with the reactive wide balance test, you want an accuracy score of greater than 80%, and then a limb symmetry index of greater than 90%. Your visual motor response time should be less than 785 milliseconds, or that would be 7.8 seconds, and with a limb symmetry index of greater than 90%. And this would be, as we spoke about, a sufficient test if used as a part of a battery. For the level 5 single limb balance, ballistic dynamic balance, right, we're looking at our single leg land and hold, our forward hop and land, and then our hop and return. And we have the specified duration of time for your time to stabilization, both in the anterior and posterior and medial lateral, as well as the resultant vector, which takes into a compilation of all vectors, both the two listed above. And then you have time to stabilization cutoff for the single leg hop forward and land with just over 1.5 seconds, and stable ankles being 1.5 seconds, and being distinguishing between that and the unstable cohort. And then you have your single leg hop and return, which incorporates both eccentric and concentric duration of time spent on each platform. And then you have the peak time, peak takeoff and landing forces. You can look at asymmetries there and time to stabilization. Because this is more of a proprietary test, the information and metrics are also proprietary, but you can also, depending on the system that you utilize, you can stratify individuals based off their age and demographic norms. Okay, I did want to provide some additional balance assessments and postural control assessments that I've been playing around with in clinic. Particularly, this stems and was inspired by the work of Dustin Grooms, where we talked about the sensory reweighting, where we're trying to have the individual in an artificial environment, just rather than the closed and predictable environment of the clinical setting. Has the individual stand on a single leg. Again, you can see that it's relatively difficult to be able to do it solely on a single leg. Oftentimes I'll have again, I'm still in the process of reiterating upon it to get the best standardization, but having the other foot just as a gentle touchdown point with less than 10% of their body weight may be a better option. And then you're looking at the center of pressure metrics that we previously looked at, as far as the total excursion, the mean velocity of the center of pressure movement, even time to boundary would be a potential example that you could utilize with this assessment. And again, this is questionable. It's still up and coming to be determined as far as validity and reliability. Regardless of whether you use it as a determining or decision factor, I found it to be relatively effective in regards to the intervention standpoint of things, and to track progress over time. And just to get standardization within the actual Beat Saber game, right? So you can set it at a select speed, and you can do it for a specific song as well, so that you can kind of quantify that, and it'll also give you a score within the game itself, beyond just what you get from a center of pressure units. And then, as I was alluding to with the different metrics, right, we've seen these before already, is a total excursion, the mean velocity, the area of the ellipse, the center of pressure range, both in the anterior to posterior and the medial and lateral directions. And though this is questionable as far as its validity and reliability, and is up and coming in the development of a test, I do believe that it has relatively good potential. And again, I find that it starts to work on the brain and some of that sensory reweighting alterations that have previously been described with lower extremity injuries. All right, and then another inspiration for up and coming tests. So the square hop test has previously been standardized, particularly within those individuals that have chronic ankle instability, right? And you get 30 seconds or the number of lines crossed. You could also just do it for time for doing 5 revolutions, and that's the number. If you want to do it for the number of lines crossed, you can see the equation there of number of revolutions multiplied by 8, the number of additional lines minus those lines that they actually step on. You can see the norms there as far as the dominant and non-dominant limb. If you're doing it for time, that is 5 rounds. You can see the seconds as far as each cohort, the healthy and the unhealthy, those that have FAI that are giving way and those that are non-giving way versus the controlled match, and relatively good reliability, as well as the standard error of measure and minimal detectable changes as shown there. That being said, taking this test and reiterating upon it so that we can make it, again, more cognitive focused would look something like this. Okay, so I call it the 4-square reactive test. So standing in the same dimension square as you saw in the previous slide and the previous standardized test that has been validated for the CAI, and then you just have 4 lights. They light up in a random order. The sensitivity of the light is set at 10 centimeters above the light, so you have to not only hop over the light, but you have to do so at over a very specified height, which gives a sense of proprioception and control with their dynamic balance, and then you would be looking at the total number of hits, the misses, and again the average reaction time. Again, this one is somewhat questionable in nature at this time. It's still up and coming, but something that I've been exploring and playing around with that is certainly a challenge more so than your standard 4-square hop test. And it has that reactive component that I've been trying to integrate into my practice based off the current literature. All right, so in summary, we spoke about the 3 different types of postural control: the steady state postural control, anticipatory, and reactive. We spoke about the stratification of these different assessments, everything from questionable to gold standard. We focused mostly on those that were probably most prevalent within the clinical setting and those that are clinically most applicable and relevant. The stabilometers, specifically the Biodex balance system, as well as force plates, are becoming more prevalent, and those would be considered to be our good ones, right? We do have the Neurocom that would be our gold standard, but are mostly found in research-based settings. We have our acceptable level of assessment that incorporates some technology in combination with the field-based testing. And then we have our battery of tests, our clustering of field-based tests that are low-tech, relatively easy to administer, have shown relatively good reliability and validity, and when used in compilation with one another can give a really comprehensive assessment of an individual's postural control. And then within those different types of postural control, we had proposed a model of a level system that would give us our level 1 through 5, with progressively challenging the individual's level of competency with their static and their dynamic postural balance. And regardless of whether you select one of the assessments that has been proposed today or utilize your own, perhaps this framework helps you to also stratify a standard operating procedure that gives a really good comprehensive means of determining someone's readiness to return to activity or return to sport, their ability to risk stratify them, and then even prescribe interventions based off the deficits that you see.